Hi, everyone. Welcome to our monthly webinar on trending beyond COVID-19. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare, and I'll be your moderator for today's session. Thanks again for joining us. The session is being recorded. During the webinar, you'll be on mute. Please submit your questions using the Q&A function in Zoom, and we'll take as many as time allows at the conclusion of the presentation. The webinar recording will be posted on our YouTube channel and on our website. A transcript of the Q&A segment will be posted on our website as well within a few days. Alexis will share the links with you via chat during the session as we do routinely. For those of you who've joined us week after week and now month after month. We have a full hour scheduled for today, so we should have plenty of time for your questions. We have a lot of material to cover because a lot's happened in the last month. I'd like to introduce our speaker, Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for our COVID-19 response. Now I'll turn it over to Dr. Harris. Thanks again.
Excellent. Thank you, Karen. And thanks everyone for joining us once again, June 2nd. So this year seems to be flying by, obviously much more quicker than last year. And we have a lot of changes, as Karen has mentioned, in regards to our COVID guidance, both from federally and statewide. And we want to talk about those activities that are germane to obviously keeping our workforce safe, and what we should be doing with regard to bringing our workforce back into the workplace. That's what we're going to be focusing in on today. And we will kick it off with going over our breakdown of the process here for our month-to-month program. If you're joining us for the first time, we begin with a clinical business case. Basically, what trend is impacting us now from a clinical standpoint in regards to keeping our workers safe. And we'll talk about what's causing, do a causal examination, a deeper dive into some of the trend that we're seeing. And we'll then begin to get into recommendations from our clinicians here at WorkCare in our thought leadership, as well as what we're seeing in clinical literature. And finally, finish out with the trending of the different practices we're seeing amongst the workforce, the mechanics around it, and then finally the messaging. So without further ado, we'll jump into our business case, which, as I mentioned, is really what are we going to do? What does it look like for bringing our workforce back from remote work, right? We call it return from home. And the question we want to ask is, what are we waiting for, right? And the business case we're going to entertain plays off of what we talked about last week in regards to creating a hyper-local scenario for the workplace. And we'll pause for a second and talk about that in case you weren't able to join us, or if you need a quick refresher. We mentioned the ability to create a herd immunity in the workplace by having a substantial number of the workforce vaccinated and not susceptible to COVID-19. And that number being around 60, between 60, 70, sometimes 80%, depending on where you live and how the virus is impacting the local community from an incident standpoint. But we know that that strategy is something that has been adopted in some cases, and we'll talk more about that as we move forward through the presentation today. So when we're talking about a return to work from home, let's take a step way back to last year, back in April of last year, when the federal government laid out from the White House, opening up America again, right? And I know it seems so distant, we may not even recall some of the ins and outs of this program, but it was How do we get people back into the workplace after the strong social distancing, strong restrictions, the stay at home measures that were in place at that time? And what we saw was, in retrospect, pretty good guidance in getting individuals back into the workplace with the social distancing, the mask wearing, and the restrictions that we've all become accustomed to. And I'm pointing this out as we look at the recommendations during this time because we want to examine what was mentioned then and compare to what's mentioned now from a federal standpoint. Obviously, monitoring the workforce for symptoms and reviewing policy for employees with regard to contact tracing, et cetera, was laid out from the government. There were various phases, as you may recall, to getting workers back into the workplace. And encouraging telework obviously was one of the first things mentioned. We know that this is now a scenario of bringing those telecommuters back into the workplace. But this program that was suggested by the White House, again, retrospectively, was well timed at that point in time and allowed us to then extrapolate from this what should we be doing in the workplace, right? And when we talk about the phase two portion of this, it included, common areas being able to open up potentially if criteria were met. When we talk about phase three, that was the unrestricted staffing, right? And so when we are considering now everything we've been through over the last year and more, we are not seeing this level of suggestion and playbook from the White House at this point in time. And so it begs the question, how can we determine best practice for our workforce as they're coming back into the workplace from home, absent of such recommendations at a high level? So we want to, again, in context, frame what we are going to discuss in a similar way in terms of not necessarily waves, but practices that may work for us from a safety standpoint. And we'll talk about a risk standpoint that is not necessarily attached to clinical determinants as well. So when we talk about examining the causal nature of this dilemma here, it deeply lies in the confusion of what fully open looks like, right? When we look at this, it is a state by state determination, not federal, right? And we know restrictions and criteria vary in state to state, even states that are by definition fully open. So now let's look at a map of the states and the current state that they're in regards of being fully open with restrictions removed, so to speak. And we can see most states by far and away, the dark blue or gray states here are open, right? The states yet to open fully, California, Washington, Illinois, Ohio, Kentucky, will be opening or are slated to open this month, the month of June, whereas Michigan and Vermont are slated to open in July. There are two states here, Oregon, New Mexico, that don't have a date yet set, but do have criteria for opening, right? And so what we want to do is dig a little deeper into, well, real quick, Hawaii, Puerto Rico, no criteria yet set for when they are to open, all right? But we want to dig into some of these criteria so that we can begin to examine the underlying cause of the confusion around what open looks like, what that means for our workforce from a risk standpoint, and we'll examine trends of these states next that have been open, and what is their scenario with regard to COVID-19 cases. Are there cases trending up, or are there cases trending down, right, or staying steady? And so what we see by far and away, most states depicted here, this reported just updated this today, of states that have mostly shrinking cases here in the blue, with new cases growing in several states, right? Arizona, DC, We're looking at California and Washington, right? So these states will pay attention to see what may be causing the growth of new cases. Already, you're thinking potentially the number of variants that are causing new cases can be a potential, but we won't examine that during this presentation. Look forward to next month as a quick teaser. And then those cases where we're not really seeing an upward or downward trend, it is not very clear here in any state at this point in time. So as we dig deeper into the criteria and what has happened with specific states, we love to pick on Texas only because Texas is one of the frontline states to take away restrictions, and their governor having done so back in May, right, opening up 100% back in March, and really, what we saw in Texas was not what some feared, which would be a spike in COVID cases, right? And when we talk about what the affected sectors were, retail, outdoor recreation, when we are considering reopening, and then when we talk about the particulars of what it looks like now in Texas, right? Mask wearing is not a requirement, both indoor and outdoor, right? So when we're looking at what needs to happen for other states to get to that level, it varies, right? And so we want to continue to look at specifically what the definition of open means, and we'll talk about now federally what has changed in regards to what we've seen play out for vaccinated folk, right? We have seen CDC publish and really simplify their approach to vaccinated individuals. Vaccinated individuals depicted here on the right, fully vaccinated, meaning you don't have to wear indoor or outdoor masks at all, right? And yes, it is an honor system at this point in time. We'll see, and we'll talk a little bit more about how that's going to play out. But for unvaccinated people, the only scenarios in which CDC says you don't have to wear a mask is if you're outdoors, running, biking, or attending a small group, in a recreation setting outdoors again, amongst fully vaccinated individuals, right? And so it's clear as to what they were attempting to promote in terms of promoting vaccine administration. And we will look at, again, how this may be adopted in our workplace safety strategy in regards to reopening and bringing individuals back. We want to look at the first mover advantage. Is there one? So far, we haven't seen one, right? And by first mover advantage, we're talking about risk, right? Overcoming two parts of risk. One, the true health risks of transmission of COVID-19 in the workplace, and secondarily, the business risks, right? And so let's examine that by first looking and recapturing the sentiment of what herd immunity is. All right. And so herd immunity, again, is a scenario in which we have enough people that are not susceptible to a particular illness such that there is low transmission. So on the left here, we see a susceptible group, an infected group, and the transmissions happening from one person to another. In the herd immunity scenario, again, we have immune individuals and we have transmission only happening in a very minimal fashion, right? And so we'll pause here to talk about some new data. There's no slide to present on it. However, there is data that is suggesting individuals who have recovered from COVID-19 may have long-standing immunity for 8 months to a year after their recovery. And the immunity that is imparted by these memory B cells, we touched on those way back when we started talking about acquired immunity versus natural immunity. The natural immunity from having recovered from COVID-19 causes your memory B cells to recognize essentially the antigen from COVID-19, the spike protein, and can be effective at warding off new exposures and risk of infection from not just the native COVID-19 variant, but also the new variants that, to an extent, some of the new variants that have presented. Now, there's more research necessary in that vein of underlying the immunity for how long, but that's positive news compared to the previous data we've seen that suggested that immunity would only last after recovering from COVID-19 for about 90 days, 6 months tops, right? Now we have talked about the variants that have populated not just from India into the U.S., but we're calling Brazil, the U.K. Variants as well as South African variants. We'll touch on those a little bit when we address herd immunity again here and the impact that herd immunity will have both in a negative or positive way on our workforce safety here. So when we look at business risk versus health risk, we're going to keep it super simple, right? The risks that we're seeing trending that are holding our workforce back from, or holding our employers back from lifting restrictions as we're bringing individuals back into the workplace. Start with just tracking vaccinations. All right, there is a tremendous pushback from not just individuals, but also from a kind of med legal or more legal standpoint of whether or not companies have the certainly have the right to ask the question, but there's still enough gray area around it that few companies we've seen to date have crossed the threshold of tracking vaccinations truly in the workplace. Certainly, we've seen what has happened in Florida and other states that have banned the vaccine passports, but this is still outside of that purview. But nonetheless, affecting our employers to the extent of the ramifications of tracking vaccinated folk in the workplace, bringing about too much litigation risk. If we look at risk of workplace transmission, and we're talking truly clinical, right, then we know that the hyperlocal herd immunity that we mentioned previously last month can produce a scenario in which low risk transmission exists in the workplace, right? And so we can create that scenario, but it does require the latter point here, which is tracking vaccinated individuals. And then lastly, risk of poor outcomes and litigation from that, right? What if a business does lift their restrictions, does have some workplace transmission that leads to poor outcomes such as severe morbidity or severe, severe morbidity, meaning, disability, or a scenario of an individual succumbing to COVID-19 as a result of a workplace transmission, right? And so there seems to be a trend of reluctance to even have a hyperlocal herd immunity and lifting restrictions because of the potential for a poor outcome and litigation happening after that scenario. So if we look at then, kind of the trend of what companies and employers are looking to as a solution for lifting restrictions, bringing everyone back from home into the workplace safely, it is looking to the CDC for an all clear, right? And inherent in that question of when will the CDC make a declaration of, hey, we're over this pandemic. It's now maybe just an epidemic like the flu, the flu virus. Herd immunity has to play a critical part of that consideration, right? And so we want to ask the question and get into the weeds around, will we ever reach herd immunity in the US? Currently, we're still only hanging out at around 40% for fully vaccinated individuals in the US. And that poses a problem, right? Obviously, we need to reach for herd immunity at least 60% at a minimum. And so, what does herd immunity look like in the US? Will we ever reach it? Is what we want to discuss now. And so, this article we're going to get into from Nature, the journal Nature, and talking about 5 reasons why COVID herd immunity is probably impossible. And this was just published March of this year. As we look at the first reason, we want to quickly talk about what the consideration and threshold is for herd immunity in this article. And they considered it at the 60 to 70% of the population gaining immunity from COVID-19. So keep that in mind. Again, we'll talk about those numbers and will we ever reach those numbers and why we may not. So the first point is it's unclear still whether or not the vaccines prevent transmission, right? This has been kind of a gray area for some time. There is clinical guidance on one side saying, yes, it can prevent, the vaccines do prevent transmission. And there's clinical guidance on the opposite side saying it only prevents severe symptomatic or symptomatic disease, not severe, but just symptomatic disease, right? And so the theory is that if the vaccines truly don't prevent infection and transmission, then obviously reaching herd immunity becomes a near impossibility because we need to prevent transmissions from happening altogether to reach it. Okay. And so more research obviously is being conducted as to the efficacy, true efficacy of the vaccines. But we do know, right, vaccines are playing a role in reducing transmissions and reducing hospitalizations and deaths as a result of us being to the point where we are with regard to vaccine administration in the US. The second reason that herd immunity may be out of our reach here in the US and globally is the rollout of vaccines being drastically uneven, as you've seen play out worldwide. We used to track in our weekly webinar vaccine administration, and we saw Israel leading that effort. And they are the nation closest to, as you can see in this depiction here, a herd immunity threshold, right? And so hopefully they reach it and we can see what plays out in Israel as a result of restrictions, as a result of they're reaching that threshold and see whether or not they have any future spikes in COVID-19 in that community. United Kingdom for receiving one dose at least is at that 35, a little over 35%. And the US, for one dose, we're over that 20% threshold during the publication of this article. At this point, we're approaching, I believe it's over 50% in the US. And for our fully vaccinated individuals, we're over that threshold of 40%, just to give you updated statistics there. But again, if we look at the disparities between how these vaccines have been rolled out from nation to nation, we can see that there is a big difference. And that difference is important because it allows the virus time to mutate and create new variants that will then potentially overcome the immunity imparted by vaccines as well as natural immunity. And again, that makes reaching the threshold of herd immunity a almost impossibility. As we zero in on variants and the effects thereof, we've seen what happened with the Indian variant, and we know that the double mutated variant can evade both natural immunity as well as some of the acquired immunity. To give you statistics on the Pfizer vaccine, particularly, the Pfizer vaccine is only 33% effective after the first dose against the Indian variant. Compare that to its efficaciousness against the wild type or the original SARS-CoV-2 vaccine or virus, and it was 80% effective there, right? And so we know that these variants are escaping some of the immunity and effectiveness of the vaccines, and that's again going to make reaching a threshold of herd immunity, both in the US as well as globally, very difficult for us. And as we talk about the longevity of immunity, we touched on that briefly here moments ago. But in a sense, if we don't have immunity that exists for long periods of time, longer than 12 months, right? Then outside of having a booster shot every 6 months or even to a year, again, we're going to be dealing with COVID-19 almost in perpetuity, and it's going to become like the flu, right? We mentioned this for the first time several months ago, but now we have more data to demonstrate that it will be a flu-like scenario, very likely for COVID-19. We even mentioned how animals such as your dog or cat can carry COVID-19 as a reservoir, and again, undergirding why COVID-19 may never go away. And I know this is not the most rosy message, right, so far, but we'll get to hopefully some pathways that we see trending that may offer some light at the end of the tunnel, so to speak. When we talk about then the vaccine effect on human behavior, there's an importance here that plays out in regards to herd immunity. And when we look at what happens with individuals who have been vaccinated, oftentimes their behavior does change in terms of going out and about, right? And when we talk about the concept of herd immunity, recall that it goes back to the notion of the reproductive rate, that R naught, right? And recall that R naught is essentially a measure of how many people are affected on average or infected on average by an individual with COVID-19 or any disease. And we know in the case of COVID-19, about 1.2 to 1.8 individuals on average are infected by one individual with COVID-19. Now, that number was derived during last year, during a period of social distancing and lockdowns, right? We saw that number be as high as 5 in some jurisdictions. And what that means and why it's relevant for behavioral changes after vaccination is all about efficacy and the threshold for reaching herd immunity. So, play out this thought experiment. An individual who was under social distancing and restrictions in terms of mobility and being out and about um, pretty much only encountered one individual, right, on a daily basis because they weren't out and about in the community. They become vaccinated and now they are back to a more social interaction. And let's say they encounter 10 people, right, on a daily basis. That changes that level of interaction, virtually changes the risk for transmission and risk for and number of R naught, right, moving it higher. And because of that, now the threshold for herd immunity also has to be higher because of behavioral changes of individuals and the number of people they encounter as a result of being vaccinated. And I know that's a kind of an interesting look at what the effects of vaccination does to individuals and our behavior, but it does have a negative effect if that is the behavior change on our ability to reach herd immunity. So, what does this mean in terms of messaging, right? As we examine what we need to communicate to the workforce, there's essentially a dual pathway for unvaccinated workers and vaccinated workers that we've seen trend. And we'll repeat that message here as we talk about the next box in this presentation. But we want to talk about how workforce has kept it simple. And we've seen it play out that way in that vaccinated people, just like CDC has articulated again, in the workplace are being treated differently than those who have been those who are unvaccinated, right? And there's a lot of nuance to this notion. And what I want to get into a little bit, just in discussion here, is going beyond the notion of vaccinated folk versus unvaccinated folk, and seeing if there's a pathway for delineating individuals who have been vaccinated and those who have been infected and recovered from COVID-19. Because we now have data showing that individuals may have a much longer period of time of immunity to COVID-19 as a result of recovering from the illness, then we should devise a way to effectively place those individuals in the same bucket as those who have been vaccinated, right? Because the period of immunity may be similar. And so, with that being said, some of the strategies we've seen play out amongst employers is doubling down on testing efforts and doubling down on identifying those who may have antibodies. Now, it's not a broad, widely accepted practice yet and still, but there is a renewed interest in those type of point of care tests so that individuals who have demonstrated an immune response to COVID-19 from a previous infection can be included in the consideration of people who have likewise been vaccinated, right? And so, again, food for thought and some of the early things we're seeing in the workplace as it pertains to how to message and treat your workers that are coming back into the workplace, and again, still minimizing risk for transmissions thereafter. So again, going back to that dual pathway and the trending pandemic here, let's touch on this again a little differently, a little bit more specifically. We've seen employers treating vaccinated individuals with no social distancing requirements, no mask wearing requirements, and they are actually putting badges on individuals, giving them a green badge for all clear to delineate them in the workplace, right? And these individuals can avoid the COVID related absenteeism from exposures and things of that nature, right? And we'll mention the potential perils of this, but the undervaccinated people, again, treat it as if nothing changes, right? Mask requirements, social distancing, screening, the whole nine, right? And so what we're seeing, how we're seeing this play out is really governed by the legal teams with our employers, right? If there is a clear path legally for them to offer this delineation, then and only then do we see this play out from a overall legal risk. And we've seen also on the flip side of that, litigation already occurring when there has been an attempt to delineate the vaccinated workforce and the unvaccinated workforce. We yet to see the outcomes of those cases, but we know that there will be some pushback from the general public. Obviously, in the case of employers, you still have an obligation to maintain the safety of your workforce from an OSHA standpoint, and we have yet to see a change from an OSHA standpoint of recommendations across the board to discontinue mask wearing, right? And so for now, the status quo, by far and large, is the going trend, right? No changes in the workplace in terms of mask requirements, social distancing, if there is no effort to document who has been vaccinated and who has immunity to COVID-19. And so what we, again, going back to our partnership with WorkCare, are able to provide kind of a hybrid in regards to tracking individuals vaccinated in the workplace. So it's not a vaccine passport, right? And in those states in which vaccine passports are an issue, then this doesn't cross that threshold. However, we're able to identify in the confidence of a clinical standpoint, right, and a HIPAA protected standpoint, PHI, those individuals who have been vaccinated, and we don't necessarily disclose that to the employer of the individuals, but rather a percentage of the workforce that has been vaccinated. And what that allows an employer to do is determine where they stand in regards to that hyperlocal herd immunity and where they stand in regards to offering a campaign, going back to messaging, that may mirror a wellness campaign, right? For example, and follow me here, if you are able to show that, 40%, 50% of the workforce is vaccinated. And reaching that 60% threshold allows everyone in the workplace to take off their masks and cease with social distancing. That becomes a very positive message to encourage individuals in the workplace to reach that threshold without ever disclosing individually who is immune and who is not, right? And so we want to be creative in our thought process, creative in our attempts to get back to a sense of normalcy, to bring people back into the workplace safely. And we are continuing to explore those type of opportunities. But again, at the end of the day, it does come down to will we reach immunity for the masses, and will there be a declaration of all clear prior to a true herd immunity? Our stance is yes, that there will be an all clear determined because the likelihood of reaching herd immunity in the US and abroad is very slim, particularly with our current rate of vaccine administration. So with that, we will hit the pause button. We'll open it up to questions and look forward to getting into hopefully a little discussion here around strategies that you're seeing play out amongst your employees.
Thanks, Dr. Harris. I just want to remind everyone to please use the Q&A function when you ask your questions. And if you have a comment, that's fine too. There's a couple, we'll start out with two very similar questions about immunity from having COVID versus immunity from vaccination, and just a little clarification of what you just addressed, Dr. Harris. The first
Absolutely.
question is it correct that the immunity from actually having COVID is much better than that gained by people via vaccination? And
that
then
is,
the other question is related. With the updated information about natural immunity possibly being greater than previously thought, how does it now compare against acquired immunity?
Sure. So what we know specifically, so to quickly answer, is natural immunity better than acquired immunity? Meaning recovering from COVID-19 gives you better immunity than vaccination. And the answer to that, as far as we know in the data, is still no, right? The vaccine imparts, in some studies, up to a 40 times greater immune response in regards to stimulating antibodies against COVID-19 than natural immunity pathway. And that has not been reversed in the clinical literature. The question of immunity longevity is what is germane to the new uncoverings of the studies that have published in the last several weeks. And it used to, we used to clinically believe immunity from the natural pathway only gave you protection for about 90 days, right? And there was some early data to suggest it may be as long as 6 months. But now we have bone marrow biopsies of immune cells that can actually eliminate the virus in culture, if you would, up to 8 months and a little bit longer out from having recovered from COVID-19. And so again, that's very positive news, but does not trump the efficaciousness of the vaccine and acquired immunity. Moreover, it is clear that natural immunity does not protect you as well against variants as acquired immunity. So the vaccine is still very important to helping prevent infection when it comes to transmission risk for the mutated virus, the Indian variant, the Brazilian, and the South African. They've all shown lower efficacy against the vaccines have showed lower efficacy against these variants, and there's clear evidence to show that the efficacy of the vaccine is still greater than natural immunity. As we pointed out a couple weeks ago when we presented data on Manaus, Brazil, that had up to 76% estimated immunity in the population, above that threshold of herd immunity, but still had a second wave of outbreak as a result likely of the Brazilian variant that played out there.
Okay, so Thanks, Dr. Harris, for that explanation. Here's someone who's surprised that you said you think we'll get an all clear from the CDC, wasn't expecting that. Do you want to tell us a little bit more about that observation?
Sure. So, it's the question of, do we in perpetuity have a scenario of social distancing requirements and mask wearing, right? And we compare that to the notion that it is unlikely we will reach herd immunity. So it used to be very much believed that we push hard, we get everyone vaccinated as possible, and we will cross the threshold of herd immunity and protect us all from COVID-19. Because that is now looking at like it's not going to be our reality, i.e., reaching herd immunity, then the other scenario of CDC determining risk overall is low enough to declare all clear before reaching herd immunity is likely the scenario. And let me perhaps reiterate that in a different way. If we are never to reach herd immunity, will we go back to some sense of normalcy at some point in not necessarily near future? It may not be until next year, but are we likely to return to some point of normalcy? And the answer is yes. We will likely have COVID-19, as briefly mentioned before, become much like the flu. And we will treat it as such. And that means we will be back to an all clear state with the notion that there will be repetitive year to year vaccination campaigns, just like we have with the flu for COVID-19, if that makes sense.
Yeah, that makes sense. Okay, jumping up to the very first questions we received, we'll take them now in order of receipt. And you mentioned, Dr. Harris, that OSHA hasn't changed its guidelines regarding wearing masks in the workplace. And I'm not aware of them really issuing anything new lately around COVID protections, except that they're trying to align better with the CDC recommendations. But the question is, what are OSHA's requirements for employers regarding vaccinated versus unvaccinated employees?
At this point, I am not aware of any delineation OSHA has come out with, and that's what everyone with bated breath is waiting for. Again, that's the alignment with CDC as it pertains to the workplace. And that's in part and partial why there is across the board kind of a wait and see and status quo that we'll keep wearing masks, we'll keep doing social distancing until we see something different play out, either from CDC or OSHA. That's specific to the workplace.
Right, okay. I was going to comment too and remind folks that the EEOC issued some new technical guidance last Friday, and we have a little summary of it on our news page on our website, but you can also check the EEOC to see what they're saying about requiring vaccination and also incentivizing employees to become vaccinated, and what laws apply from an equal employment opportunity standpoint, which would be the ADA, the Civil Rights Act, and GINA, the Genetic Information Non-Discrimination Act. So there's a trickle of more guidance from that respect. Next question.
Well, real quick, I'll even add that if you look at the CDC guidance on mask wearing, even for vaccinated individuals, it still says the exceptions are, right, for vaccinated individuals when state, local, and or workplace requirements dictate otherwise. So again, they kind of give the caveat that if you're an employer or a local jurisdiction, you still call the shots on whether or not individuals have to wear masks. Certainly, we're privy to that here in Illinois and Chicago, in which in the city, we still have to wear masks, even though outside the city, jurisdictions have decided otherwise in certain scenarios.
Yeah, that corresponds with a comment from one person who says she lives in Texas, and even though the governor has opened things up, at least in Houston, businesses are still requiring masks, and you have to have one on to enter. So I'm sure it's playing out that way a lot of places.
It certainly is.
Next question. This is specific to one type of employee who's vulnerable. What precautions should we take for a vulnerable employee who's been at work all this time but isolated? And then now with others coming back to work, he may need to be in contact with them. Should we perform an antigen test or antibody test on this employee? What other advice do you have?
Sure. So this is an interesting scenario. Again, one of the onus on the employer to protect the workforce from unique exposures in the workplace. And certainly that is part of the consideration that we've seen play out even in schools, right? Where now, where mask requirements in schools are now in some states, right, it is not even a possibility per several governors, right? And parents have spoken out against it, saying if my child has a unique immunologic deficiency and they're at risk, then having unvaccinated, obviously in this case, kids under 12, unmasked presents a unique exposure. So too in the workplace, bringing individuals back with no masks and using an honor system to determine who falls into the category of not having to wear masks from vaccination poses a problem, right? And therein lies some of the risk from a litigation standpoint if there is a transmission that leads to a poor outcome. So again, the pressure is to stay status quo. There hasn't been, again, outside of actually tracking individuals' vaccinations and confirming their status, outside of that, doing testing has been deployed as suggested in the question, but it's still not popularly accepted to do antibody testing because it's kind of a yes or no. There are a few who are trying to do what are called titers and looking at antibody levels to COVID-19, but still there's not enough clinical substantiated data to suggest at what level or what threshold an individual has immunity to COVID-19 or does not. So there is no clear best practice with regard to deployment of antibody tests for immunity at this point in time.
That's interesting. Because remember early in the pandemic, there was a lot of interest in that, but then it never really quite got traction for the reasons you just described.
Indeed.
Next question. With the possibility of a longer immunity timeline from COVID infection, could this be calculated for herd immunity within a workplace along with vaccination rates?
So I think there is a pathway there. And certainly internally amongst the physicians that work here, we've discussed a strategy for trying to help our employers determine such. But again, it requires testing to be front and center for those individuals who have possibly recovered from COVID-19. And we do have some employers that have elected to increase their focus on testing in the workplace. But again, it's not the testing for do you have COVID, it is the testing for have you recovered from COVID with the IgG and the IgM tests that we spoke of very, very long ago, early in the pandemic. So we do look to, I think we will look to an alternative pathway for determining who is and who is not susceptible in the workplace. We just haven't seen an upward trend of that as of yet, and any best practice pathways as of yet.
Okay. So this next question, I think we could probably do a whole webinar on it because it's a really interesting one with lots of possible answers. With ever-changing, contradictive information almost daily, how do we communicate health risks in the workplace? Should we check daily and educate continuously? People don't trust information being communicated, leading them to make decisions based on emotions.
And that's certainly true. And even adding to that, the substantial data substantial data around misinformation, right? It's hard to determine and discern what information should be paid attention to and what information is unfounded. Um, I hope that, and thank you for the question, and thanks for attending. That as a resource for certainly vetted clinical information. You rely on us as a trusted partner, and perhaps that's an argument for us as a clinical group to find a way to communicate more frequently outside of the weekly webinars we used to do, ways to give you valuable insight to what trends are relevant and what trends are not founded in the data clinically as well. So, duly noted on that point of providing. Now, I do encourage you to check out our publications that come out on a more frequent basis than monthly. That Karen, who leads this webinar every month, does put out from her team. So, but we'll brainstorm ways to get more accurate information more timely to you, because you're right, it does change daily and it is awfully confusing, which adds to the sentiment of mistrust in the public.
Yeah, I just wanted to mention too that I did write something on misinformation a while ago that I can send to Jennifer. It's also on our website. I think it was a blog I did a while back, maybe 6 months. I'll look it up. Next question. Does the medical community encourage people who have had COVID to get vaccinated? If so, at what point after their infection?
The answer is yes, and there is no hard, fast rule on how long you have to wait. There's no required waiting period other than being asymptomatic, meaning you don't have a fever or cough when you go to get vaccinated. So, provided you're asymptomatic after you've recovered from COVID, you can go get your vaccine.
And regarding the 60% value that you showed on one slide, the 60% value seems low for having a mask-free workplace. Can you expand on how this value was obtained? You might want to go
Sure.
back to that slide.
Certainly. So the 60% value the value for any herd immunity is predicated on the local, both national and local incidents, right? And so, for example, when we talk about herd immunity as it existed in New York, with the reproductive rate of measured up to 5, meaning 5 people on average were infected by one individual with COVID-19, their herd immunity threshold was 80%, compared to the national average of about 1.2 individuals infected by one person with COVID. An R naught of 1.2 would mean that 60% of a population would need to be immune or not susceptible to COVID-19. And so the answer for our workforce and what we've guided our employers on that have chosen to take the pathway of tracking vaccines so that they can potentially reach a herd immunity locally, is to look at what the local incidence is and base your threshold on that number, that R naught number, and that corresponding herd immunity percentage.
Okay, great. Thanks for explaining that. Next question. And I just want to remind everyone we're going a full hour, so we'll be concluding in about 5 minutes. Now that science is finally recognizing innate immunity, is it plausible that employers will cover T-cell testing for employees who suspect they were infected early on in the pandemic, but who never had a positive PCR test?
So, in terms of strategy, I think that would be a plausible and solid strategy for bringing individuals back into the workforce, with the notion that, again, we're not going to reach a vaccinated herd immunity. because as we look at the test available, it's still not widely available, right? We just haven't seen the manufacturers increase the utilization of these titers. Now, I'm putting on my hat of cynicism around capitalism, and I would gather that although we know these tests exist, i.e., Pfizer used them during their clinical trials, if we demonstrate that individuals have recovered from COVID-19 and they have long-standing immunity, they may not need a vaccine, which obviously hits the underlying bottom line for a manufacturer of vaccines. So there's my often rarely communicated hat of cynicism. But at the end of the day, I still question why we have not seen that pathway of testing individuals with titers in the same way we have with other illnesses such as hepatitis B, that you have to have a titer in order to be a healthcare worker in the hospital after you received your hepatitis B vaccine. So why we haven't seen a light speed effort for titers is still a question mark I have as well.
Okay, next question. What are your thoughts about people
meant,
coming to work?
What? I meant to say warp speed. Sorry.
Oh, sorry. I couldn't hear you. What are your thoughts about people coming to work with common cold symptoms but without a fever?
Sure. So we reported on that, I believe, last month or the month prior, right, where we showed statistics of, I believe it was 92% of the workforce has admitted to coming to work ill, right? And obviously, what that suggests is, whether you have a fever or a cough or the sniffles, you still, even if it's a common cold, may transmit in the workplace illness that causes and does contribute to absenteeism. And we even looked at what the numbers are associated with that level of absenteeism resultant from sick people coming to work. The breakdown further looked at why people still come to work sick. I believe around 42% said they didn't want to use their sick time. Another chunk said that they felt they had too much work to finish and they couldn't take the time off, right? And so now moving kind of towards what the future may look like for all of our employers that have rolled out and continue to do screening, symptomatic screening on a daily basis, is an opportunity to pivot into how do we keep not just COVID infected individuals safely at home, but just sick individuals altogether. Certainly we saw less flu as a result of the measures, safety measures put in place because of COVID. And I think there's an opportunity to leverage some of the tools we've used to prevent COVID transmissions in the workplace to also help prevent other common illnesses that can cause absenteeism.
So that answers another question asking for your opinion on continuing temperature checks for employees as it would relate to potentially catching someone who's infectious from coming into the workplace, regardless of what their illness is, if they have a temperature.
Indeed, what we've seen in terms of trends from our employers is a lot of employers moving to automated temperature checks using infrared thermography, basically kiosks, if you would, and even the cameras where individuals walk past them, they're quickly imaged and their temperature taken from an average of their face, and they're able to pass through if they are negative for a fever. So gone or fleeting are the days of having a staff person sitting and scanning one by one individual temperatures as you enter the facility. But the future will likely still have these technologies that can automate that process, as it will exist likely in airports and other public venues in perpetuity.
Okay, we're almost out of time and we still have some questions left. So we'll answer those that don't get answered in writing, so check our website. One last question. Sorry to everyone else, we just don't have time to take them all. Since the states just started lifting restrictions, is it true it will take another 2 weeks to truly see where the U.S. stands with COVID-19?
It may take that and a little bit longer. And I mention that because we know the variants that are here in the US are likely to still increase in their transmission. And the one that gives the most pause is the Indian variant that we know has been documented here in the US that has caused the second wave in India. So I think we will see over the next 14 days, which is, on average 7 to 14 days, the average incubation period, what will play out from the Memorial holiday gatherings in terms of transmissions. And certainly over the July 4th holiday, we may see another increase. And just as we showed today, California, Washington, a couple other states are still seeing increasing new cases, all right, not decreasing. And so if we see a trend in the wrong direction, we're likely to see it in that timeline after these holidays for sure.
Okay, as usual, Dr. Harris, we really appreciate your time and attention to this. I forgot to mention earlier, for those of you who are still on the call, that we're going to be doing a special one-off webinar on June 23rd on marijuana in the workplace. And it'll be a clinical and regulatory update from Dr. Jeffrey Jacobs, who is the head of our medical exams and travel division, the vice president for clinical activities in that department. So I hope you'll join us for that. We'll be sending out information about that today and for the next couple of weeks. Thanks again for joining us, and thanks you, Dr. Harris. Take it easy, everybody.
Thank you all, and always be safe and God bless.